Welcome everyone, and we are back for, I think, our fourth webinar this year in our free webinar series as part of GDR. Today we're excited and it's a pleasure to welcome Dr. Nick Beech. He's a maxillofacial surgeon based on the Sunshine Coast. He's also a friend and colleague. We studied in Adelaide together at one point as well, and he's someone who's recently started up his own private practice out there. So for those who are based in Queensland, please have a look and reach out. He's got an interest in orthognathics, implant and grafting procedures. And today it's going to be talking about a topic that I think is relevant to all of us, which is the surgical considerations. Extractions is a mainstay of, bread and butter dental practice, but it's also considering, okay, what are the long-term replacement options? And obviously in this day and age, implants has become a huge kind of option and opportunity in terms of a treatment choice. And something that we should be considering. And so there's a lot to digress and discuss in that area, from, patient factors, medical history, procedure itself, and different options in terms of grafting and how that then influences the overall outcome and survival and predictability. So we'll touch on as much as we can over the next 30, 45 minutes. We welcome questions. Dr. Nick Beech is also involved in a lot of research. He was involved in master philosophy back when he was doing his dentistry. But now he's kind of supervising PhD students and further research, again, in those fields of orthognathics and grafting and others. So I welcome Dr. Nick Beech. Give us a further welcome if he wants to. And otherwise, we'll get started into the presentation for today. And then, like I said, today is really about answering the questions that you have as well. So please ask as many questions as you can.
Thanks, Alex. My name's Nick, and I've known Alex for a while, back when we were in Adelaide together, just surviving. It's very strange doing a talk like this because I can't see anybody except for Alex, so I have no idea if I'm even talking to anybody. But if you do have any questions, please send them through and I'll do my best to answer them. This is a big topic. I'm trying to keep it general, trying to keep it relevant, but it's a lot just to cover in half an hour, how to take a tooth out if you're wanting to put an implant in that space down the track. So I'll get started. What this talk is about, firstly, it's about making a hole and filling the hole. So how to assess prior to removing a tooth to avoid trouble, some procedural considerations for the extraction, and then the same for augmentation as well. A little bit on material selections and procedural considerations. Patient selection, this is the most important thing. This is much more important than your grafting material or your membrane choice, anything like that. Patient selection is key. So I think that we would all agree that before you do an extraction, you need to consider and discuss the final outcome. What is going to happen in this space? Is there going to be a tooth replacement? Is there not? And what are you going to put in there? Everyone wants to talk about implants, but they're not the only replacement option, and they're not always the best option. Not everyone's suitable. Not every site is suitable. But you should have a restorative treatment plan. But we're not going to talk about bridges and dentures and things. We're going to talk about implants. So as a general rule, just have yourself a little checklist. Is this person suitable? Prob's not. If they've got perio, they've had radiotherapy. Osteoporosis, that's controversial. Bruxism, smokers, they're unreasonable. They got poor oral hygiene. They're, skeletally immature. There's many, many others, but have a little checklist in your own head before you even talk about it, because next minute you'll be trying to fend off all the questions about implants in someone who's just completely inappropriate for them. In terms of extractions, medical assessment is required. There are general health factors that will either risk your intraoperative complications, any kind of uncontrolled disease, in particular cardiovascular disease and coagulation disorders. So things that are going to cause you a problem during your procedure or in the immediate post-operative period. And then looking a little bit further, what's going to cause issues in the coming days to weeks. They're immunosuppressed, smoker, diabetes. Are they going to get an infection? Are they going to get dry socket? Are you, they're going to be calling up? Are you going to need to see them multiple times, debride the site, etc.? Particular medications we really care about: anticoagulants, anti-resorbatives, and immunosuppressants. Now, anticoagulants obviously increase the risk of bleeding, but when someone's on an anticoagulant, you should be thinking, okay, why are they taking this? I had one the other day, you ask them, oh, why are you on these medications? And they said, well, actually, I had a heart attack 3 days ago. Okay, well, maybe we should, reevaluate doing something today. Anti-resorbatives, Prolia is really common these days. You should have an idea as to how that works, how you time it, and how you manage it. Just briefly, it's not a contraindication to dental implants, but there are some important ways that we need to manage it. And immunosuppressants, so steroids, and increasing the risk of infection or potentially implant failure. If they're on long-term steroids, the mucosa is going to be thin, they're going to heal poorly. Do you need to give them an additional dose of steroids with any kind of procedure? One thing that's becoming a lot more common are these monoclonal antibodies. So these are biological agents that are used for many different things, like rheumatoid arthritis. These are important because they do have a risk of medication-related osteonecrosis, and they've got they're relatively new, some of them, and not well understood. And same again, cytotoxic agents, again, increasing the risk of infection. Medical assessment for implants. There are very few absolute contraindications to placing an implant for a medical fitness perspective. Now, the ITI has guidelines for what they would consider to be straightforward, advanced, and complex. And these are the key ones on the medical history that come up. There's a checklist you can run through the website. Compromised immune system, so that's all those immunosuppressant medications, smoking, irradiated bone, or bone metabolic disease like osteoporosis. Patient selection, this is the most important predictor of success. Much, much more important, as I said, than whatever material you want to use. Choose very carefully who you treat. You can decline or refer treatment you're not comfortable providing. You will get a lot of patients try and push you into doing something that you're not comfortable with, whether it's from an urgency perspective or a financial perspective. Just be careful who you treat, and if you do that, you will always sleep soundly at night. So you've got a patient who needs a tooth removed, and they want to have an implant down the track. So come up with your team as to how you want to manage this. Now, this team could just be you. In the surgical phase, have a think about whether or not this patient and this tooth is suitable for you to treat for the extraction. A risk assessment for the medical history for the tooth. Do you have provable training for extractions? Do you have the technical ability for this particular tooth? And can you provide them the appropriate aftercare? And if not, is there someone in your practice that can do it, or should you refer it to a specialist? If you don't have these skills, CPD like this is how you can develop those skills. And most maxillofacial surgeons I know would be happy to have dentists come visit them, see how they do things, myself included. Now, for the restorative phase, same again, do you have the skills to perform this procedure? And if not, who can you contact, or who can you ask for help? Alex asked me to talk about Anaesthetic Choice. Local anesthetic, IV sedation, and GA are the ones that I use most frequently. I don't use a lot of nitrous because I've got access to IV sedation and GA options. In terms of local, anything can be done under local for the right patient. This guy took his appendix out under local anesthetic, his own appendix. General anesthetic, again, very safe, effective, and accessible. And I say accessible from a maxillofacial perspective. I know that it can be quite a challenge from a general dentist perspective to access general anesthetic in some areas. This is very controlled, and we can offer this for the majority of patients for most procedures. I'm seeing a rise in IV sedation in a dental setting. Maybe it's to try and meet that issue with general anesthetic access. I have an anaesthetist that I work with. We do it in my rooms. It should be considered a high-risk environment. This is an unfamiliar situation for most people unless it's done regularly. Resources are always going to be limited. Skill mix is definitely going to be different to a hospital general anesthetic. And you should carefully consider whether you start to do this, consider the guidelines, have documented procedures and protocols for how you manage any kind of issues that might arise. Financial considerations. Again, you just don't want any surprises. So any Radiohead fans there, informed financial consent. Patients need to know what they're in for. If they don't and they get a nasty surprise, they're not going to be happy. So they very clearly spell out what's going to happen, how much they're going to pay. This is where, if you don't explain this carefully, you can get yourself into trouble with complaints. They should know before they get into anything, before they start down this process. Doesn't mean that when you take the tooth out, they should be quoted for the implant, but you definitely can. And they should have a rough idea as to what the steps are going to be. In terms of rebates and things like that, maxillofacial surgeons, we have access to Medicare benefits schedule, prosthesis list, and things like that. And so the financial considerations can be a little bit different depending on what space you're working in. Okay, making the whole. The goal should be a comfortable, quick procedure with a quick recovery, and patients should be kept well aware as to what's going to happen next and how long they're going to be out of action. You want to preserve bone where you can. So minimal bone removal, avoid, and that's just not, preserving bone is not just about not taking it out. It's about avoiding excessive forces on bone. So smashing it with, cow horns or like grabbing it with extraction forceps. Fractured bone often dies. Excess heat onto bone if you're not irrigating effectively. So preserving bone is not just about not taking it out. It's about managing the bone that's there. And again, you'll preserve bone by preserving the blood supply. Minimize your periosteal stripping. Gentle tissue handling and correct flap design will help preserve bone. When you're making the whole, hard tissue assessment, soft tissue assessment, and an occlusion assessment. So we're thinking about what we're going to do with this hole once the tooth's gone. Do we need to graft, and what kind of grafting do we need to do? Is it hard tissue? Is it soft tissue? Are they going to bite on our grafting site? Can we put an immediate implant in? And do we have a provisional plan? So if we're taking out a front tooth, are they going to walk out of there with a gap? Or can we defer this until they've got a provisional plan? Tooth assessment, looking at the vital structures. So most important, the floor of the maxillary sinus, the inferior alveolar nerve, mental foramen, and any kind of adjacent structures that can be injured. The tooth morphology can give you clues as to if this is going to be a difficult extraction, whether there's minimal crown structure left, bulbous roots, multi-rooted teeth, the tooth type or location, so impacted teeth, canines, very long maxillary premolars typically have long spindly teeth, spindly roots rather that fracture frequently, and maxillary molars with the risk of oroantral communication. So factors that will make a tooth removal difficult, absent crown, decayed or minimal coronal structure, heavily restored, ones that you touch and they just explode. Is it part of a bridge that you're going to need to section? Are they adjacent to heavily restored teeth or an implant that interfere with the where you can apply your forces? And where's your application or lever point going to be? Root assessment, root treated teeth, very brittle, they fracture frequently. There can be resorption and ankylosis. Root fractured teeth, again, you might find that as soon as you touch the tooth, now you've got a root that you have to dig out. Bulbous roots, and where you're going to, how you're going to remove those, preserving bone, spindly roots, trying to avoid keeping them fracturing and retaining them. Dilacerated, splayed teeth, apical lesions that you might need to debride, posterior maxillary teeth with the risk of fracturing tuberosity or sinus, and mandibular teeth close to the inferior alveolar nerve. So when you're assessing the tooth, is there any information that you need to make your assessment more accurate, like a CT scan? And just as a guideline, there's lots of indications for extractions for third molars, but for other teeth as well, and particularly for ones where we're thinking of doing an augmentation procedure. Are you thinking about doing a sinus augmentation and you need a 3D assessment of the sinus? Are you considering immediate implant placement and you want to plan your implant as well? Is there a pathology that you need to navigate, or deep impaction of the tooth? In terms of what anesthetic you choose, local anesthetic is best for a few teeth, minimal quadrants, a short procedure, and a patient with low anxiety. Obviously, you can do it on many, many different people, but when you're trying to provide a comfortable procedure, these are key. Medical compromise, this is for people that are just not suitable for any kind of sedation and you're forced to use local anesthetic only. IV sedation, I touched on before, is riskier, so we like to be very clear with who we choose for this. They need to be fit and healthy. They need to be mobile and cooperative. Mild to moderate anxiety, they're not great choice for highly anxious patients, but they are good when we need to manage multiple different teeth or place multiple implants. A procedure that's moderate length. And if you have any concerns about whether your patient or your procedure is suitable, just have a chat with your anesthetic provider. General anesthetic, any patient that needs high-level support, very anxious or potentially uncooperative, pediatric patients, higher risk of complications that you may want other resources around, ways to control bleeding, etc. Patients getting multiple teeth removed or complex teeth, extensive grafting procedures, and patient preference. It's their choice in how they wish to be treated. Lots of things to consider with a surgical plan: adequate consent, pre-procedure rinse, use of antibiotics. This should be a sterile or as close to a sterile procedure in dentistry as you can get. You should be using, for any kind of surgical procedure, you should be gowning, surgical sterile gloves, some kind of prep or pre-procedure rinse and draping. Topical anesthetic choice and local anesthetic choice, what kind of flap you want to use, take the tooth out, close it up, and have your post-op care. So in terms of flap design, think about what you want to achieve and what's your final plan. Do you want to have primary closure, or are you happy to leave the socket open? Are you going to place an immediate implant? Are you going to need more access for grafting and placement of a membrane? And what do you need to do to get the tooth out? There's no point making a small flap if you know that you're going to need to do extensive guttering and sectioning. All you're going to have to do is either stop and make a bigger one, or you're going to start to traumatize your flap, or you're going to start retracting it more and it might tear in ways that you don't want it to go. Don't rule out plan B by choosing plan A. If you start raising a large envelope, but you wish you had done more of a 3-corner flap, etc., One of the rules in surgery is that big mistakes are made through small incisions. So just make sure that your exposure is adequate for the procedure you want to do. Consent the patients. They need to know common risks, rare but serious risks, what a reasonable person would want to know, and what this specific person would want to know, even if it's quite rare. You need to touch on the expected benefits, the nature of the procedure, alternatives, and informed financial consent. And all this should be documented, because if you don't document it, you didn't talk about it. Options for your rinse. I use chlorhexidine pre-procedure rinse. For major cases, I might use a betadine, half-strength betadine prep or rinse. Antibiotics. Again, this is starting to get a little bit controversial as to the use of antibiotics. Generally, we're trying to move away from using or minimizing our use of antibiotics, but there's still a large number of indications where they are effective in improving outcomes. And the type of procedure you're doing and the type of patient you're doing it on should be the main factors whether you choose antibiotics. It shouldn't just be your default or routine. And think about before you do the procedure, do you need any blood tests? Do you need an INR because they're on warfarin? Do you need to manage or stop any medications? Do you need to talk to their medical provider as well? All of this done in advance means that you can just show up for the procedure and all the decisions are made, and you can just focus on doing a good job rather than worrying about, oh, what's the blood test? You know, that causes anxiety, that causes stress. Just try and keep it all controlled. Here's a list of equipment that I like to use. There's lots of different things that you can use. The whole point of this is have a plan A, B, and C. The tooth won't necessarily just come out with forceps. You might need to do a surgical, and you should be able to advance along these steps into, okay, plan B, surgical, plan C, we need to go deeper. Have a surgical motor and a handpiece available, or a piezo if you've got the patients. Choose your burr correctly. I like to use a Fisher burr. It removes bone less. It makes accurate sectioning possible. And have consumables available, things to manage bleeding, variety of sutures that you might need. And if you're doing grafting, a variety of grafting materials and other options available just in case you need more, or you need a different one, or someone drops something on the floor. Intraoperative techniques, again, good flap design, soft tissue handling. Just be really gentle with the soft tissues, because at the end of the day, that's where large amount of your blood supply is going to come from. Remove the tooth as atraumatically as possible, and then consider your grafting. So I keep coming back to this picture of this lateral incisor, because this is a patient that I had recently that I thought has a lot of these key points that we can run through in a moment. Grafting materials. There's so many options out there. Every company will tell you that theirs is the best, and they'll show you fancy graphs that show that they're better than everything else. I like to let the patient decide what they want to use. So in my practice, I'll give them the options of their own bone, synthetic bone, a xenograft like BIOS, collagen, or a cadaveric bone. So the patients can choose, but there's also other considerations. How big is the defect? How many walls is the defect? How much bone do you need? Which will impact the donor site if that's if they're using their own bone. The different materials typically will have evidence to show, okay, how much bone at 3 to 4 months, which is when you're doing your early hard tissue healing for implant. How much bone you're going to have at 6 months, which is your late placement. You should have an idea on the cost and how these materials handle. Membranes, again, lots of different options. Most important ones are probably collagen, whether it's a fast resorbing collagen membrane like BioGuide, or something that's quite slow like Symbios. Other options like PRF, gel foam, non-resorbable options do have their place. For those ones, I don't use a lot of those ones except for titanium for more like a larger defects. And are you going to expose this membrane or are you going to bury it? Everyone's going to have a different idea as to what they do. For me, I like to use xenograft or cadaveric bone as the patient likes. I don't find alloplast or synthetic bones to be as effective. Autogenous bone, so the patient's own, will give you better early bone, but now you've got a donor site. And if you're using xenograft or cadaveric, it is more effective to mix it with some autogenous, whether you scrape it from the side or you take it out of your implant drills. Xenograft collagen membrane, and I tend not to have any membranes exposed, but there's definitely situations where that would be effective. The reality is nobody wants to use their own bone. Everybody wants the best outcome. Cost is one of the biggest factors. Graft materials are expensive. Membranes are very expensive. You need to factor in how much time, how much money you charge per hour, and add the extraction cost. And if you're adding all this up and telling them that they need to have this, you better believe that it's worth it, because the costs stack up very quickly, and some people are going to think you're ripping them off. So for me, I just ask my patients to decide. I decide who are suitable for implants, and if they want them, would they benefit from grafting, and the patients get to choose what type of graft they want to use. Grafting 101, atraumatic extraction, remove the whole tooth, don't leave bits behind. Absence of pus or infection. I don't like to put any grafting material if there's suppuration. Chronic infection is a different story. You can graft into chronic infected sites and cystic sites, provided you've decontaminated and cleaned it well. Mobilize the soft tissues, periosteal release, and primary closure. You want to put grafting material to the level that you want bone, and then extra because you're going to lose some, and you need to secure the membrane. So you want good stability. For aesthetic zone and other ones, consider connective tissue grafting as well. The reality is extract the tooth, curettage, wash it out, pack your grafting material, collagen membrane of your choice, secure it to periosteum or bone with pins, or making sure your particulate graft is stable, close the site. But there's lots of protocols. Does socket preservation work? There's two phases in your post-extraction changes. One's the initial vertical loss, and then secondly is the contraction of vertical and horizontal bone. Socket preservation can halt phase 2, but it doesn't have any, or has very little benefit to the first phase. Reality is there's a broad range of published outcomes as to whether or not socket preservation works. They all seem to lead toward an improvement, but 0.4 to 4 millimeters on the vertical, or 0.8 to 2 millimeters on the horizontal compared to a normal healing socket. It's hard to know what to believe, because a lot of these studies are going to be published by people trying to sell a product. Negative outcomes are not reported well. But you need to think about, okay, with that in mind, will that amount of bone make a difference in this site? And for non-aesthetic zone sites, or those with intact walls, it's really not going to make a big difference for a lot of patients. And just anecdotally, as socket preservation becomes more common, I'm seeing a lot more foreign body reactions from socket preservation attempts that result in fibrous tissue ingrowth and foreign body reactions. And these are patients that have had a tooth out, it's been grafted, and they're just ongoing pain and symptoms from the site. You can see the material there's had a foreign body reaction, and it's just turned more like a fibrous union rather than any kind of bone. And if they just left the socket there, you probably would have had bone. Okay, so our case that I showed you with the lateral incisor, this patient came to see me, they were in pain. They had a draining sinus. They had a root-treated lateral incisor with apical changes. They were fit and well with low aesthetic demands, but it was an aesthetic zone tooth. There was very minimal but present labial bone. She did want an implant, but she was very happy to accept a removable temporary, which she had already had made. So considerations here, she needs treatment to manage this infection as soon as possible. I would like to graft the site, but putting that into pus I think would lead to a high chance of failure. She may need soft tissue grafting as well as hard tissue grafting. She has a high aesthetic demand, so we need to work out, when are we going to do the grafting? When are we going to do the implant? And would we do it as a single or two-stage procedure? So here we have this one. Treat the infection as soon as possible. Antibiotics is not going to treat that. So we took it out under local anesthetic, controlled the infection with post-operative antibiotics. I saw her a week later, and we had a CT scan done. There was no grafting done at the time of extraction, but we planned for a two-stage approach. So she was happy with an immediate temporary denture. Our plan is to place an early implant, so soft tissue healing, graft the jumping distance, graft the labial with either a cadaveric or xenograft, bury it, and then keep any kind of connective tissue grafting up our sleeve for the second stage procedure. There's lots of different ways to approach these kind of patients. So I know that was seemed a bit rushed. There's lots of talk about it. Happy to take any questions or talk about anything in more detail if anyone has any questions they want to ask.
Thanks, Nick. Appreciate the talk, and maybe we'll dive into a few questions. I don't know if you've got any cases, or we can kind of discuss them. But if anyone who wants to reach out to Nick, like I said, he's based in the Sunshine Coast. He's got his contact details there, which we can bring up a bit later. You brought up, I think, the socket preservation, and I think for those who start to do more and more of that procedure, and whether they use, as you say, xeno or allograft materials, you start to see, there's certain cases where you wish, perhaps that fibrous encapsulation, and it's sometimes hard to understand why that fibrous encapsulation happened. So I was wondering, and obviously there's sometimes the case where residual infection or granulation tissue that wasn't removed, but have you kind of seen other reasons or hypothesized other reasons why you're seeing that kind of fibrous encapsulation in times when you wouldn't expect it, or in many cases where that hasn't been the result?
Yeah, so I think some of the ones I've seen, they've got retained endodontic material there, and it can just be like a little bit. So obviously the infections still remain. So before you graft, decontaminate the site. Traumatic extractions as well. None of these people who come, they talk about having a nice quick extraction. It's always like the worst day of their life. They always talk about how they were picking pieces of bone out of their face for months. So perhaps there's a role in there in that, the bone was quite injured. Yeah, those would be the key ones. And then your usual things. So people at high risk of infection, smoking. But whenever I've seen these people, touch wood, I've not had one of my own that's come to me, but I think it's inevitable the more of these cases you do. There's always like a really long story about this tooth. It was never like, oh, I had that tooth out and it was grafted and now I've got a problem. It's always like, first I saw the endo, then I saw this guy, then I saw da, 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 da. Yeah, there's always a big story and so multiple procedures. Yeah.
No, that's interesting. I've had a couple in the last year or so, and couldn't give you we can always say that there was maybe something residual left in the socket, but then you come back to it and nothing. So no, definitely interesting. What, in terms of, I think what you touched on in terms of like patient selection, and sometimes patients aren't the right patients for implants, and is there something that you're seeing in perhaps not just new patients, but perhaps patients coming back with problems, a pattern or something that you've kind of noticed is different or is not what you expected, or perhaps, a certain graft or certain, methodology would have been different in terms of how you approach it for that patient who is a higher risk patient?
Yeah. I mean, the obvious ones are people who bleed. They're on multiple medications. You'd love to stop them where you can, but most of the time, there's a reason they're on it, so you should continue it. I think it's the important thing is like patient selection, yes, but it's not, patient selection is not just about saying, I will only treat the easy ones. It's about predicting complications. So seeing people, telling them that they are a high risk of these things, so that when they do have that issue, it's not you thinking in the back of your mind, oh, I knew you were going to get that. It's them being aware that you have had the foresight to identify this. You've taken some steps like post-operative antibiotics or chlorhexidine rinse, or, that they feel that you're not just winging it. So they're aware, they know what to look out for. And then just keep in touch with your patients. So post-operative care is important. So when they do inevitably get a complication, they see you and you can manage it, and they know that they can get in touch with you early and that you'll see them and that you'll take them seriously.
Yeah. And that's like the early part of healing, and then you've got the long-term maintenance, and those patients who are smokers or peri or immunocompromised, inevitably, we look at the data, 20% over a 10-year period will come back and need further surgery or have complications. So definitely. Got a question from Kevin. What does the typical atraumatic extraction look like for you? The process, instruments, and perhaps we can talk about a molar and an anterior, and what's the difference in your approach? Maybe let's, what is your typical?
I don't get the luxury of anterior teeth unless they're attached to someone on a million medications. So
I was going to say that lateral was a good example.
I don't get
that was your only anterior case in the lab. But let's say molars, what is your approach? And we can, I'm not sure if you have a difference for, let's say, upper molar versus lower molar.
Yeah, so I take it probably one of the more common teeth I do is upper sixes. So we'll do it for that. Atraumatic extraction. So we do our consent process. We have our plain films. I tend not to get a lot of CT scans for simple extractions like this. We've done the consent. Let's say we're doing it under local anesthetic. They have a chlorhexidine rinse. We put a drape on, sterile gloves. I use a headlight, and I use topical local anesthetic, a little pellet, because I care. But I don't know if it makes a difference. I use articaine for almost everything under local anesthetic. So infiltration and a greater palatine block. For an upper six, I would routinely do an envelope flap, raise a very small flap, section the crown, look at the root structure, section the roots individually, and take them out. So for an upper six, atraumatic for me is minimal buccal bone removal. So you basically a sectional removal with a small flap.
And then you sectioning, you mentioned is most Max Fax, I'm guessing you're using a straight hand piece, are you using a contra angle?
In my rooms I have NSK. I use a slightly angled, so 45. It's like a 20 degree. I think it's about 20 degree. These ones, the high speed NSK, so it's like a 2-to-1. So it's about 80,000 RPM electric drill. And I use a Fisher burr.
And I think for those who, and perhaps maybe we can post later in the study club, but having the right length burr is quite important.
Yeah, so the burr should be the correct one for the drill you're using. So just know that some of these surgical handpieces want long shank burrs, some of them want short ones, and there's a million different types of burrs out there, whether the length of the cutting surface or what it's made out of. Horses for courses.
Absolutely. I have found though in experience, if they're too short in length, that especially the deep root sectioning, depending where the fusion of the roots, sometimes you can get limited. And for those starting out, sectioning the crown will give you much better access and understanding that root morphology. that you otherwise may not appreciate through the crown. Are you using luxators? Are you using forceps? Do you have a particular way you approach that upper root? You know, let's say commonly that mesiobuccal root, perhaps it has a C curve to it, or a slight, angulation where it is difficult to rotate out. You know, do you section that further, or what's your approach?
Yeah, so you take the crown off, and then you're looking at I guess the root structure. I make like a little Mercedes sign to separate the roots, and that's where that's I guess the point where the root's going to rotate out of. So you can be generous with that tooth removal, interradicular tooth removal. But after that, it's a 3 millimeter curved luxator or straight luxator. Root forceps for the palatal root can be useful because it can be quite long and difficult to get a nice elevation point. But otherwise, it's luxators every day.
Yeah. And what about for a lower molar?
For a lower molar, again, this is where I might do a little bit more buccal bone removal. Or even just kind of like interradicular removal. So you raise your envelope flap and then you look for the furcation, removing some bone around there. These are ones where I might use forceps. Otherwise, if it's just 2 roots, just split it straight down the middle and take each root out individually.
Yeah. And I think you kind of touched on a point of creating enough space for yourself in the interradicular is what gives you the space to move the root into that space and, elevate it further. Because I think sometimes when we start sectioning, if you're using a thin burr or not giving yourself enough space, you might feel that that root is getting jammed, and it's just due to the fact that you just don't have enough space for it to elevate through. SK asked a question. So what do you think about using a red band high-speed or surgical handpiece? So these are usually rear venting, I believe. And then I just find a surgical handpiece very slow when it comes to sectioning.
Yeah, I mean, I only have surgical handpieces because I don't do any kind of restorative work. So, but I know what you mean. So if you have like a typical surgical handpiece that's like a low speed or low torque, like the older style NSK ones, then they're terrible at sectioning, and you'll often see if you try and put a Fisher burr in them, you can see it just slipping. It's actually not the friction grip is not working. Those kind of handpieces are good for a round or rose burr for bone removal, but the moment you try and section a tooth, it's just not adequate. So the way I get around that is the equipment that I use is the NSK. It's a 2-to-1. I forget the term, but it's basically a high speed. It's 80,000 RPM, and it the other option is like an Elcomed. Those kind of setups with the right Fisher burr, they just will cut a tooth like butter, really. So it depends on the equipment you got. So there's surgical handpieces and surgical handpieces. But I couldn't comment on using a red handpiece because I just don't do that at all. But definitely turn the air off if you do.
I think for those using that red band, I'm guessing perhaps these are maybe the electric motor handpieces. In terms of sectioning, it's the surgical handpieces that you can get and especially if you're going to get into doing more of this, it's just best to have that right system from the get-go, and avoiding that risk of emphysema, especially if if things change and you do go into raising some sort of flap, or if you're into the bone and if the sinus is near as well. And in terms of the RPM, I think you've answered that question as well. In terms of, so you talked about that case as a type 2, and if anyone's got any other questions in terms of anteriors, let's talk about canines, upper canines or lower canines. What's your preferred removal of that? Because obviously, if the bone isn't soft, or if there's quite a bit of cortical integration, if it's a long root, or especially if it's more of an oval shaped root kind of complexity, you're not able to rotate that root out.
Yeah.
And then you often lose that buccal bone if you are pushing in a buccal blade, and unfortunately there's buccal bone 17 mils down the root.
Yeah. I hate canines. That's like the worst. They are the worst of all.
Thankfully, they're the two that we extract the least, but they are the worst.
Yeah. Canine stubby forceps for those ones where you can. This is where you might find that you're doing a bit of labial bone removal, so raising a flap and doing that. The bone over the outside of a canine is going to be very thin at best in most people. So no matter how you take that out, you're going to lose
that bone.
Yeah, you're going to lose that bone.
Yeah.
So you can plan it a bit better and just take it out, or take some of it out rather. Just because it's got a single root doesn't mean you can't section it. If you get the angulation right, then you can do that to make some space. But really trying to take it out with forceps, if you can, that's going to be the most success. You can approach it from the side, make a hole in it as well, and get like a Warwick James and try and lever it up. That's another option. Yeah. But yeah, you're in for a struggle. For any canine that doesn't want to come out nicely with forceps is going to be a pain, no matter what you do.
Yeah. And in cases where you are having a difficult extraction and you are thinking of placing an implant, and let's speak to an upper molar for hypothetical sake, what are you, if you're envisaging it's going to be difficult, are you thinking of grafting? We talked a bit about timing. I think for those who don't have experience with different graft materials and their handling, and there's pros and cons to different ones, as we've kind of discussed. If you are using something that's more xenograft, there is a slower resorption. Sometimes if you come back around 4 months, the bone still has a lot of nice white fluff around it. However, if using allograft or the cadaver kind of base bone, but there is a higher resorption, so there's pros and cons. But if it is a complex extraction, or there is going to be that buccal bone loss, how are you approaching that for a molar and then an anterior site?
Yeah, so like for an upper molar, in terms of grafting those ones, I always try and think about whether or not these people are going to need a sinus lift anyway. Because if you're doing socket preservation, but at the end of the day you need to do a sinus lift, then you should be kind of stepping back and perhaps doing that at the same time as the extraction, or just letting it heal naturally and then coming back and doing your sinus lift and grafting procedure down the track rather than socket preservation. But if they've got enough height and it's you think it's going to be suitable, then same as any other site. So yeah, xenograft, cadaveric bone, collagen membrane, and sutures.
And are you getting primary closure? So do you like to move that mucogingival junction?
Yeah, if I'm grafting, I do like to get primary closure. There are lots of membranes that you can leave exposed and get more keratinized mucosa, but if your goal is keratinized tissue, then perhaps you should let it heal and then graft later. But if your goal is bone, then getting some bone in early, and move the tissues across, and then perhaps move them back when you place your implant. So for people that have got lots of keratinized tissue, you can shift that. But if you're trying to increase that, you're better off just letting it granulate and heal and deal with the bone later on. The soft tissue is, you're a periodontist, so the soft tissue is more important in a lot of cases than the bone. Much easier to get bone than it is to get soft tissue.
I mean, both can be hard. Both can definitely be hard, and I think there is a shift, a push from patients to do less surgeries and try and get as much done in one go. And I think it's also kind of that setting of expectations and a patient that's difficult with an extraction is, can be difficult for a whole process of procedures that maybe you don't want to embark on to begin with.
Yeah.
No, that's been really great. Does anyone have any other questions in regards to extractions, considerations? One thing I do, using that lateral as an example, what's your preferred way of degranulating sites of infection? And, again, perhaps how you approach a upper molar where perhaps the granulation tissue is approximating the sinus, or a lower molar, or anterior again.
I use a sterile saline and a Lucas curette, which is like a flat, sharp curette. So have some different sizes, and when I'm cleaning it up, the main thing you want to know is, is the nerve going to be at the bottom of this socket? And is my vigorous cleaning going to interfere with that? And same for the sinus, am I going to create an OAC by trying to vigorously debride this? Those are the two.
And in those cases, I'm assuming you don't vigorously debride it. Perhaps...
No, you don't. Less concerning around the sinus, because if you've got a large cyst that's invaded the sinus floor and things like that, that's easier to manage. But yeah, around the nerve, yes, you are just being careful, and maybe you're just leaving some of that, not grafting, letting the infection resolve before you go back and do that. Yeah.
Have you had any experience with any burrs or using burrs for degranulation?
No. Well, not really. Like for actual odontogenic cysts and tumors where we need to do peripheral ostectomy, yes. But otherwise, no, I don't. I don't do it.
Wilson, we'll finish off with Wilson's question unless there's another one. What goes through your mind if a root breaks? Are there scenarios where you think it would be okay to leave the root?
Yeah, so we do coronectomies for lower third molars often. So that's an intentionally leaving the roots behind. And I warn patients, if I taking, let's say I am planning on taking the tooth out and not doing a coronectomy, I tell them if the root breaks off, low down, we're leaving that alone. It may cause some issues down the track, but trying to get it out is a much higher risk of causing a problem. So, I would say that the times to leave a root is when removing it is going to cause more problems than getting it out. So lower third molars close to the nerve. Maybe if it fractures low down in an area that you're not planning on putting an implant in. I know people have put implants through roots and things like that. It doesn't make me feel comfortable. Otherwise you should be trying to get it out or sending it to someone that can get it out. Those would be my thoughts.
Yeah. And I think, part of that is that assessment of, does that tooth have a history of, a root canal infection? Is there any periapical or pathology around that root? I think, all too often you see, as you said, kind of cases where GPs left, or, infections weren't degranulated and kind of returning to that site. You can see kind of that persisting fistula. And often, in the healing, if things are healing well, that's great. If they're not, as you mentioned, there's kind of chronic discomfort in that area. And often, sometimes if you use a perioprobe, you can find a little fistula that's formed as well. Well, thank you everyone for a lovely evening. Thanks everyone for joining. If you have any questions, please reach out. Through the study club, maybe we'll post a few links to some of the handpieces that Nick uses and some of the burrs that he's finding useful as well.
Cool. Thanks, Alex, and thanks everyone. And I don't know if you got any other questions, you feel free to email them through or get in touch with Alex. And
absolutely. And thanks everyone again. All right. See ya.
See ya, Alex.